Hi, my name is Dr. Stephanie J. Nahas. I am an associate professor of neurology and UCNS board certified headache specialist at Thomas Jefferson University in Philadelphia, Pennsylvania, where I also run the Headache Medicine Fellowship Program. I'm joined today by my esteemed colleague, Dr. Adam Sprouse-Bloom.
My name is Adam Sprouse-Bloom. I'm a family medicine doctor. I've also done a fellowship in headache medicine, certified in headache medicine, and I do both see patients with headache and do headache research, and I work at the University of Vermont.
And both of us, as co-chairs of the First Contact Headache and Primary Care Initiative of the American Headache Society, are grateful for your interest in today's program.
So these are our disclosures. I'll give you a second to look at them. So let's go into our learning objectives. We have 4. The first objective is defining migraine. What is it? The second is discussing how to distinguish migraine from other headache disorders. Third is we want to talk about acute treatment, prevention, and other management strategies. And lastly, we want to dispel some common migraine myths. What's migraine? So most people think about migraine as migraine equals bad headache. But in reality, you can actually have migraine with no headache at all. All of the symptoms of migraine are just as much migraine as the headache. So sensitivities to light, to noise, to smell, nausea, a sense of disequilibrium, pain at the base of the skull. All of these symptoms of migraine are just as much migraine as the head pain. So it really is a all systems disorder. Migraine is a very prevalent disease. 1 billion people worldwide have migraine. 1 in 5 women, 1 in 16 men, 1 in 11 kids, and people don't often realize that. 1 in 4 homes have someone with migraine. Migraine is broken down into episodic and chronic. This slide that I'm showing you here shows the distribution, the percentage of days that, of how many days people have migraine. So you can see most people are in the 1 to 2, 2 to 3, or 4 to 6 days per month in which they're affected with migraine. But a significant proportion of people are affected more than that. The cutoff between episodic and chronic migraine is half the month. So 15 days per month or more with migraine symptoms, and you qualify as having chronic migraine. And the reason that's important is having migraine, chronic migraine, is associated with higher levels of disability, higher healthcare utilization, higher absenteeism, higher presenteeism, in other words, showing up to work but not working at full capacity. If you have chronic migraine, you're less likely to be employed and you have a lower quality of life. I'm going to turn it over to Dr. Nahas now.
Let's take a few minutes to dissect migraine attacks. What typifies the disease of migraine is these recurrent attacks of a particular nature. And as mentioned before, the frequency of these attacks defines whether a person has episodic migraine or chronic migraine. These attacks can take on many forms. What you're seeing on this slide is not really an exhaustive list of all the symptoms that somebody may experience during migraine, but it covers the broad spectrum of that experience. The attack can actually begin hours to days before the individual realizes that they're having a migraine attack with these early symptoms or premonitory symptoms, prodromal symptoms. We believe that these are linked to dopaminergic activation within the nervous system, leading to symptoms such as yawning, nausea, neck stiffness, unusual food cravings, thirst, increased urination, even cognitive changes and fatigue. Following that, a person who has migraine with aura, and about 30% of people with migraine will experience aura with some, if not all, of their attacks. They start to get some other more obvious neurologic symptoms that come on slowly, hit a crescendo, and then fade away gradually. The most common type of aura is visual in nature, the so-called scintillating scotoma, which is a dark spot which appears in the periphery of the visual field, soon followed by what we call fortification spectra, or zigzag lines that shimmer and can take on very pretty colors. And over time, over the course of several minutes, this will start to grow and spread across the visual field until, for some people, their vision becomes completely obscured by it, literally blinded by their migraine attack. Other visual phenomena can occur as well: kaleidoscope vision, simple spots, or colorful shapes. But it doesn't have to be visual. It can be somatosensory, where there's tingling, prickling sensations crawling up the arm and into the face. Or it could be vestibular, where vertigo comes on insidiously and then grips that individual. There can be speech changes. There can be other cognitive changes. In short, it's the gradual development, crescendo, and spread, and then fading away of some sort of neurologic phenomena. Then what everybody thinks about with migraine is the head pain, that moderate to severe throbbing, pounding pain that tends to be on one side of the head and limits a person's physical activity. In fact, most people with migraine will say that they have to be very, very still because any physical activity or even simple head movement will aggravate their pain. In addition, during this headache phase of the attack, it's very common to have sensitivity to light, noises, odors, and even other things in the environment. The skin may become sensitive, particularly in the scalp, but it could be all over the body. And nausea, sometimes along with vomiting, is also pretty common at this phase of the attack. Now you'll see that little blue line that continues during this phase. Those early symptoms, they can take a long time to resolve and just add to the burden of what a person experiences when they're having a migraine attack. Finally, and thankfully, the headache pain starts to diminish, the prodromal symptoms start to go away, but this resolution phase or the postdrome then takes over. Many people will describe this as the migraine hangover, where they still feel really fatigued. Their neck maybe still feels a little bit stiff. They might still kind of feel that brain fog. And knowing that the prodrome can be a couple of days, a headache, the full-blown migraine attack can be up to 3 days, and that resolution phase could be another day, somebody might be in a migraine cycle for most of the time if they have fairly frequent attacks. Now you may be wondering, how does this all happen? What's going on in the brain that a person can have this awful experience that's so fully featured? Well, on this slide on the pathophysiology of migraine, what we're depicting is just a tiny piece of the puzzle of our understanding of why migraine occurs. So what we see here is the trigeminal nerve, and the trigeminal nerve is key. It's probably considered the root of migraine, and it connects to lots of different structures, peripherally and centrally. So the trigeminal nerve innervates sensation of the face, the dura, the blood vessels, pain-sensitive structures of the head. But it also can communicate with other circuits through the trigeminal ganglion and the trigeminocervical complex. Through this interplay, this cervical complex is where we believe the neck symptoms may come from. And through the trigeminovascular complex, this is where we believe some of those vasoreactive changes, the blood flow changes, and perhaps even the throbbing quality of headache pain may occur. What sets this whole cycle off, though? What causes these circuits to reverberate in a way that is a terrible experience for the individual? And how does that individual experience it in the first place? How does it become translated? Well, we conceptualize that deep in the brainstem where the trigeminal ganglion is sort of running the show, the signals get sent up through the brainstem to the thalamus and then eventually the cortex where the person has the experience of all of these symptoms. This is why somebody can say it feels like somebody's hammering their head or driving an axe through the skull. It's not actually happening, but that's the perception that that person has because of the way the circuitry is misbehaving. And why does this circuitry misbehave? Well, that leads us to our discussion of the newest drug target in migraine, calcitonin gene-related peptide, or CGRP. Now, this is a fairly ubiquitous neuropeptide, but it's most concentrated in the trigeminovascular system and the dura. There's also a lot of CGRP in the gut, and that may speak to how it actually acts in the body, and it also might be relevant as to why gastrointestinal symptoms can be common in migraine attacks. So something flips a switch that activates the trigeminal nerve. It starts releasing a lot of pro-inflammatory mediators, including CGRP. And then what CGRP itself can do is lead to these vasoreactive changes where the blood vessels can dilate and constrict and become floppy and throbby, where they can become inflamed along with the dura. In fact, some describe this aspect of migraine as brain hives because the dura becomes so inflamed that it then becomes painful. And every pulsation of the vasculature becomes sensible, and that sensation is amplified and turned into throbbing pain. It's just, one of the theories. But furthermore, CGRP enhances neurotransmission, and in particular, nociceptive neural transmission mediated by the trigeminal nerve through the trigeminal ganglion. I'll turn it back over to Adam at this point.
So let's talk about people with migraine. Where do they go? So about 2/3 of people with migraine come to you. They don't go to neurology. They don't go to other sort of specialties. So it's not an uncommon chief complaint. Unfortunately, migraine often goes undiagnosed. So about 56%, more than half of people with migraine are never diagnosed with the condition. And that includes a lot of people that come to us complaining of symptoms that meet criteria for migraine, but they are kind of left out there floating, never being able to kind of hang their hat on a diagnosis that they have. And sometimes people float around to various specialties before they end up finding that they meet criteria for migraine. So how do I diagnose migraine? Well, the first thing that we often think about is making sure it's not something else. And usually it's not. So there's a mnemonic called the SNOOP mnemonic, and the SNOOP each stand for signs or symptoms that the patient may have that don't mean necessarily that they have a secondary headache, but it should raise an eyebrow and make you think, okay, maybe I need to get imaging, or maybe I need to order labs or consider other non-migraine diagnoses. So some of the SNOOP signs and symptoms are, systemic symptoms, fever, weight loss, secondary risk factors, some form of immunocompromise like HIV, neurologic exam. So the neurologic exam for a patient with migraine, for all practical purposes, should be normal. Onset, so a sudden onset or thunderclap, which is defined as onset within 60 seconds or less. An older patient, so, an uncommon story for someone with migraine would be, I've never been a headache person, and now in my 70s, I developed migraine. That would be a story for a secondary headache, so late onset. Although migraine often pops up around hormonal milestones. So onset of periods, so menarche, birth of a child, or menopause. So it's not uncommon at the headache clinic for someone in their around 50 to present with migraine, but you still have to think about it. Changes in pattern, this can be tricky because migraine can shift itself, but for someone with a stable pattern of migraine to develop a change, that should raise an eyebrow. And precipitants, you shouldn't be able to really trigger a migraine attack. The International Classification of Headache Disorders is available on Google. It's easy to pull up on your own. And I frequently, when I'm seeing a patient, will pull it up and I'll look at the criteria. And the reason being is the criteria for tension type headache and migraine overlap to some degree. So you can see that for migraine, 4 to 72 hours versus 30 minutes to 7 days in tension type, right? So there's a full overlap there. One-sided, but bilateral in 40% of people with migraine, and more typically bilateral in tension, right? So we don't understand migraine or tension type fully. ID migraine, it's a 3-question screener. So P, I, and N, PIN, the migraine diagnosis. P for photophobia, does light bother you when you have a headache? I for impairment, has headache limited your activity for more than or equal to 1 day in the last 3 months? And N, PIN, N for nausea, are you sick to your stomach when you have a headache? So if a patient says yes to 2 of the 3, or 3 of the 3, then there's a 93% chance that they would meet criteria for migraine. So now let's get into our how do you treat it? So we broke how do I manage migraine down into 4 sections: acute treatment, prevention, non-medication treatments, and managing what makes migraine worse. So first, acute treatment. So there's really 3 boxes the way that I view acute treatment. You got your migraine-specific medications. Up until recently, that only included triptan medications, of which there are 7. So sumatriptan, rizatriptan, et cetera. gepant medications, which is a newer class of medication that works on that CGRP system that Dr. Nihas alluded to. And there's one ditan currently, which has a similar mechanism to the triptans, except that it works on a slightly different serotonin receptor and was created because it's safe in people with heart disease. The second sort of box of medications that I pull from for acute treatment are the anti-inflammatories. So common ones include ibuprofen or naproxen or diclofenac. And the third box is a group of dopamine antagonists. Most people think about these as nausea medications, but turns out they're also good for the head pain of migraine. So the common ones are metoclopramide, prochlorperazine, and promethazine. And what I often do is I'll equip a patient with one from each of the boxes, and then I'll encourage them to treat and to pick from their box based on the severity of their disease, of their headache. And this is called stratified care. And this has been shown through research to be a patient-preferred method of treating attacks. So the idea is if they have a mild headache, they might just pick one. I picked an NSAID because that's a common thing that a patient would pick, but you could just pick a triptan to begin with. If they have a moderate attack, maybe pick two of them. You know, it might be a dopamine, it might be metoclopramide plus a triptan. And if it's going to be a doozy, I do what I call a power pack. Pick one from each and take all three. And all of those medications can be repeated, each at a different, interval. So there's 7 different triptans, which I mentioned already. And honestly, insurance, to some degree, influence the order in which we prescribe them. A lot of insurances tend to prefer sumatriptan, rizatriptan, elatriptan, naratriptan, and zolmitriptan, not necessarily in that order. Some of them allow you to pick sort of, whichever one out of that group. Sumatriptan, every insurance would allow first. And there's some unique distinctions between them. For example, elatriptan is preferred in pregnancy because the lowest, almost none, gets into the breast milk. A couple of them come as nasal sprays, so sumatriptan and zolmitriptan, and the mode of delivering a triptan influences how quickly it works. Sumatriptan comes as a subcutaneous; it's the only one. Frovatriptan has a very long half-life, so it's typically not used for attacks because it takes a while to work, but it can be used sort of for prevention. So if you have a known time that you're going to have migraine, so say I go on an airplane and when I fly I get a migraine, either on the way up or on the way down, you could pre-treat with frovatriptan or even naratriptan, which is the next longest half-life, or around menses is a common one. So we're going to do some back and forth with some pearls for acute treatment. Dr. Nehas, say you have a situation where you're taking care of a patient and they find that their triptan is not effective. What would you think about?
This is a very common scenario and one which I want to be less discouraging when both patients and clinicians understand that we have options. So just because one triptan doesn't work doesn't mean that they're all not going to work. So try a different one. Or maybe consider that it wasn't given at the proper dose or the proper time. Or maybe it needs a little bit of help, like adding another adjunctive medication, an anti-inflammatory, dopamine antagonist, etc. Maybe some patients always need that power pack that Dr. Strauss-Bloom alluded to. They always have to treat with a combination to get the best results.
Yeah, that's been my experience too. In the headache clinic, I often find people come on triptans, but say they come on, like sumatriptan comes as 25, 50, and 100, and people often show up with 25s or 50s. I almost always give a full dose. What do you do?
I do as well. Unless I've got a strong reason not to, I'll typically give the 100 milligram and I'll say, you've never tried this before. What do you do when you're getting used to something? Maybe just try a half dose. And maybe a half dose will work, but maybe it won't. But at least you'll know if there are side effects, they'll be at about half the intensity as opposed to if you took the full dose. You also want to make sure you're not turning your patient off from triptan therapy right from the get-go. And there are people who don't really tolerate the 100 milligram very well, but they can take 50 and then another 50 to smooth out the side effects and still get the relief that they need.
What if a patient takes a triptan, but they get a triptan side effects such as tightness of the neck or the chest?
Yeah, fiddling around with the dose doesn't help with that. Switch to one that has a better side effect profile. And based on a meta-analysis, the triptans with the best side effect profiles are naratriptan and almotriptan. To a lesser degree, rizatriptan, elatriptan, and zolmitriptan also have fairly decent tolerability. And again, this is compared to that sumatriptan 100 milligram dose.
Say you have a situation where the patient treats with a triptan, it works, but then the headache comes back a couple hours later. What would you do then?
Yeah, this is another common stumbling block that we encounter in headache medicine. And again, we would consider this a triptan failure for this specific reason of recurrence. And it's something that we measure in clinical trials with acute therapy. How often do the symptoms or the pain recur? So something that's got a longer half-life might make that less likely, not necessarily. Half-life doesn't always translate to the duration of the effect of a medication. Always keep that in mind. But again, maybe it needs a little extra help with an adjunctive medication.
What about a patient that has nausea and vomiting?
Well, in that circumstance, it can be tough to swallow a pill. And so look for something that goes by the non-oral route, a nasal spray or an injectable. In addition, you could always try to combine an antiemetic of your choice before the triptan to prevent that escalation of nausea, which may lead to vomiting. That's one of the side effects of triptans, is that it can accentuate nausea in particular, but all migraine symptoms may be accentuated temporarily until they're relieved. It's a peculiarity of the triptans.
What if a patient is overusing triptans or other acute treatments, such as NSAIDs or others?
Yeah, this is a great point. These medications are meant for attack therapy on demand, but not to be relied upon as maintenance. And when a person starts relying on acute or on-demand treatment too much, they can get into what we call rebound headache, or medication overuse headache is the current technical term in the classification. So not only do we have to address that pattern and curtail the use, but we also probably at that point need to institute preventive therapy or migraine reduction treatment, and we'll get into that later.
And lastly, what about a patient that can't use triptans? For example, they had a history of a stroke or a heart attack.
Right, or they've tried all 7 and they didn't work. We'll call them triptan failures, or we'll call the person triptan failures, of course. But in the setting of triptan failures or triptan contraindications, you might consider using something that's potentially gentler and potentially safer, in particular with vascular disease. And as Dr. Sprouse-Bloom mentioned, the GPANs and the DITANs were designed in part with that in mind, because these medications do not lead to vasoconstriction, at least not directly. We have no evidence to suggest that they can cause vasoconstriction, whereas we know that triptans can. And this is why triptans are not a good idea for anybody with active or unstable vascular disease. Now that we've talked about some of the details and ins and outs of attack therapy or acute treatment, let's switch gears into preventive treatment or migraine reduction therapy. First of all, when do you prescribe or consider preventive therapy? It all revolves around the burden of disease. So take into account how much migraine itself interferes with the day-to-day routine for that individual. How frequently are they having migraine symptoms or frank headache from migraine? What do they conceptualize as the level and intensity of the burden of their disease? Do they want something to help reduce that burden, or do they want to just keep dealing with the attacks? Most will say they need to deal with the attacks, but they also would like something to help reduce that burden. And that's where patient preference comes in. And as mentioned before, when there's too heavy a reliance on acute medications, or if they don't work, or if they're contraindicated or simply are not a good fit for that individual for whatever reason, preventive therapy should definitely be prescribed to help reduce the burden of disease. There's also a suggestion that adequate preventive therapy can make acute treatment more effective. Who is eligible for preventive therapy? Now, we talked about what constitutes eligibility, revolving mainly around the burden of disease, but how many people with migraine does that really apply to? So on this slide, we tried to depict for you visually a visual representation of the totality of people with migraine. And many of them have 3 to 4 attacks per month or fewer, 3 to 4 days per month or fewer, if you recall from an earlier slide. But those who have more frequent attacks, and we have this cutoff at about 4 days per month, which is about 1 day per week. And you can shift that number again depending on how burdensome and bothersome the individual attacks are. Somebody with 2 attacks per month that takes them out of commission completely could qualify for prevention just based on disease burden. Then again, somebody with 5 attacks per month that they're able to manage and go about their day might not qualify for prevention. So it's around 4, but anywhere between 2 and 6 generally. Most of us would agree that above 6, we should institute prevention, because we know from epidemiologic data that over time, higher frequencies are a risk for progressing to even higher frequencies in the future. So we get a number that's around 40% of all people with migraine are eligible for prevention or really should have it. But the sad thing is, under 15%, estimates are around 13%, of these people actually are prescribed preventive treatment. Now that we've discussed who's eligible for prevention, how do you select what that preventive medication is? We have a long list to choose from, multiple different classes, multiple different mechanisms of action, some of which are FDA approved, some of which are more creative solutions or related to the medications that are FDA approved. So we have to take into account patient characteristics, patient values, and patient preferences. So at this point, I'm going to get into a conversation with Dr. Sprouse-Bloom about key considerations when you have a patient sitting before you, how to select among literally dozens of choices, what's the one that's most likely to be best for them at that point in time. First example we'll point out is migraine plus a diagnosis of hypertension. What are some key considerations?
Right. So this is a situation where you want a twofer, a lot of people would want to try, and sometimes that works. And sometimes I find that I end up doing sort of a mediocre job at both things, but it's worth a try at many times. So migraine plus hypertension, consider a beta blocker. Also, the ARB candesartan has some evidence.
Now, migraine is comorbid with some other disease states. And by that, we mean there are two diseases occurring in the same individual more often in the population than just random chance. So somebody with migraine is more likely than somebody without migraine to also have depression or anxiety. And also the vice versa is true. And we see this very commonly. Patients come to the office who have migraine, but they also have depression or anxiety. So what can we do to maybe leverage a twofer there?
So that's a common situation. Tricyclic antidepressants, so amitriptyline or nortriptyline are common options in those settings. Also, there's some evidence for venlafaxine.
Similarly, insomnia is another comorbidity to migraine. And what can we leverage in that regard?
Amitriptyline and nortriptyline tend to make people tired. Sometimes they wake up groggy, particularly with amitriptyline, nortriptyline less so. I tend to tell people to take it, after dinner as opposed to right before bed.
I would agree. I find that strategy to be helpful too. Now, migraine disproportionately affects women, and particularly women of childbearing potential. So what are some of the most important considerations in that regard?
Yeah, valproic acid is teratogenic, as is topiramate. And so you want to avoid those in women of childbearing age. And if you do consider prescribing, you have to ensure that they're on sufficient contraception.
It also relates to the larger discussion that we should always be checking in with our patients who are women about any plans that they may have for pregnancy, because it goes beyond just prevention and acute treatments and what you can and can't do, but migraine can change with pregnancy, as was alluded to earlier. Now, obesity is another one of these comorbidities to migraine and a risk factor for progression. So what do we do about that?
So topiramate has some weight loss properties. So does the related medication zonisamide.
Now, let's say you've got a patient who's tried this first preventive that you were sure was going to be the home run. It was the perfect one for them, but it fell flat for whatever reason. Do you give up there and look for other alternatives, or is it worth trying something else?
So if the problem is that they had an issue with the medication, a side effect, for example, I would try a different one, the second one on my preferred list, and which could change for each patient. But if the issue is that they tolerated the medication, but it just didn't give them adequate relief, say they went from 20 days a month with headache down to 10 days a month with headache, I would add a second layer of migraine prevention.
Now, we've all encountered patients who've tried at least 2, if not 4, or if not 10 oral medications. And again, for whatever reason, they just didn't work out. Is that the end of the road?
No, so there are some newer options that are available, and insurance typically requires failure of at least 2 oral options before they would be approved. But there's some new monoclonal antibodies and also onabotulinum toxin A, which is injections every 3 months. Those could all be considered in settings such as that. There's also procedures for migraine. So these are the 3 common ones. There are nerve blocks. There's a lot of peripheral nerves that come, around the skull or through the skull. And, you can block many of those. The picture here demonstrates occipital nerve blocks, which is a common peripheral nerve to be blocked. And you don't just have to do occipital nerve blocks for people with occipital neuralgia. It's commonly used for what's called salvage therapy to break a cycle of a runaway migraine attack. Onabotulinum toxin A, there's 31 shots in the scalp, neck, and shoulders, and that can be very effective for people. It's done every 3 months. And the third image shows trigger point injections, and there is a role for those in migraine as well, so procedures for migraine. So we've talked about preventive treatment. Now let's talk about some non-medication treatment options for your patients with migraine. So there are some devices. There's actually 4 of them that we have here. The first one is a transcutaneous supraorbital nerve stimulator. It is placed on the forehead, and it's similar to a TENS unit in that it induces a contraction of the muscles of the head. There's this transcutaneous magnetic stimulator placed in the back of the head. You flip a button and it'll induce a magnetic pulse applied to the back of the head. There's this armband, which is remote electrical neuromodulation. And when you turn it on, it triggers sort of a buzzing, compressions in your arm. And lastly, there's this non-invasive vagus nerve stimulator, which is a nerve stimulator that's applied to the front of the neck. When you induce a treatment, you can get kind of a pull at the muscle. And the mechanisms for these are all FDA cleared. Medications are FDA approved, devices are FDA cleared. So it's sort of a different threshold to make it to market. But these, all 4 are FDA cleared, and there's variable degrees of evidence for each of these. Supplements or nutraceuticals. So the ones that have the best evidence include vitamin B2, which is riboflavin, magnesium, CoQ10, feverfew, and melatonin. So look at the doses here. I find that magnesium 600 is hard to find in a single tablet or capsule. It's often in 400s, sometimes 500s. You probably have similar experience. CoQ10 is typically in hundreds, and it was studied 100 milligrams 3 times a day, which is a little bit preventive from, and it's also the most expensive. The evidence for feverfew is low quality, and for melatonin, there's evidence, but it is conflicting. You might have heard or even given pedicides or butterbur. The current recommendation is not to use it. Dr. Nahas, what do you tell patients as it relates to pedicides?
Yeah, it's a tricky situation. Now, when pedicides, butterbur root, is not processed properly and the extract is not extracted properly, there can be leftover toxins that can be damaging to the liver. And there have been reports of patients using butterbur or pedicides products and having significant liver damage, even leading up to a liver transplant. Thankfully, these reports are rare, and most butterbur products are processed correctly. Where the huge controversy came in was a particular brand had been approved in Europe based on their purification process. They changed that process to improve it, but they didn't go through all of the steps to make it kosher with all the regulatory bodies in Europe, and therefore it's been banned in a few countries. Because of this, and because of the concerns, and because of the litigious society that we live in, many of us have shied away from proactively recommending butterbur products, except in situations where we really have almost nothing else, and we have a fully informed consent discussion with the patient, that we want to monitor their liver enzymes and be aware that liver abnormalities can occur with butterbur treatment. Thankfully, I've never encountered it as a problem. And if I have a patient who comes to me and is already on butterbur and they're benefiting from it, I don't tell them to stop it. If they're interested in butterbur or pedicides extract, I just have the conversation about what the potential risks are, and they're usually agreeable to it.
So there's also behavioral therapies for migraine, and these all have grade A evidence. They're supported by data and they're endorsed by the US Headache Consortium guidelines. So biofeedback, cognitive behavioral therapy, and relaxation training. And use of these is sometimes affected by resources in your area. So if you happen to work in a city, then maybe you have access to providers or clinicians that can provide training on these. You know, there's obviously online resources, and some patients are more adept at accessing and utilizing those than others. But these are allow patients to avoid pharmaceuticals, which is something that we all strive for. I'm now going to turn it over to Dr. Nahas to move from non-medication treatments to managing what makes migraine worse.
Indeed, let's not forget this fourth critical aspect of monitoring your patient with migraine to make sure you're assessing for things that can lead to disease progression. I mentioned earlier that the frequency of headaches is one of those indicators. The higher the baseline frequency at year 0, the greater the chance that the frequency is going to be even higher in year 1, year 2, and beyond. So if frequency is increasing, you need to dial up the intensity of your treatment. And if that person's not on prevention, they're going to need it. We mentioned already that excessive reliance on acute medication not only is bad for that person, it can lead to toxic effects, but it can spin migraine out of control. The worst actors in this regard appear to be opioids, butalbital-containing medications, combination analgesics, and unfortunately triptans, one of our best weapons against migraine. But again, when used judiciously, these things can certainly be helpful, but patients have to know they have to limit them. And by the way, we want to avoid opioids and barbiturate-containing medications whenever possible. They really should be a last resort and probably left to a specialist. Depression, we mentioned that as a comorbidity to migraine, along with insomnia and anxiety. It might not be obvious that somebody has depression, so you need to be on the lookout for some of the more subtle symptoms. A patient might just tell you that they're having some trouble sleeping, and it's not just insomnia. That's one of their symptoms of depression. And so you want to delve a little bit deeper as to why they're having insomnia. Maybe it's anxiety-based, maybe it's depression-based, maybe it's a mixture of the two, or maybe it's something else completely. But we routinely screen for depressive symptoms and treat it when it's present, because we also know from epidemiologic data that uncontrolled depression can also be associated with uncontrolled migraine. Other pain conditions can also interfere with migraine management, especially when those other pain conditions make that individual take pain-relieving medication more often than they should. So this is another scenario that we encounter not too uncommonly, where a patient is getting worse and we haven't identified that they've got back pain for which they've been taking anti-inflammatory medications very frequently, or maybe even an opioid once in a while. If you only ask about what medications they're using to manage their headache pain, you might miss out on an opportunity to counsel them on curtailing use of pain medication for other reasons. I like to tell my patients, your migraine doesn't know why you're taking that medication necessarily. When you take it for back pain, it counts against your monthly limit for migraine, even if you're not having a migraine attack that day. Asthma is another comorbidity. These entities on the allergic spectrum, which would include asthma, are again comorbidities to migraine, and certain medications might be contraindicated. For example, with uncontrolled asthma, you don't want to use a beta blocker, of course. So when you identify asthma, make sure that it's well managed so that it's not, again, something that you may see as a hurdle to overcome in managing migraine. When it comes to obesity, there are some medications you want to avoid, maybe some medications you may gravitate to because they may have weight loss as a side effect, but also addressing it directly with nutritional advice and a graduated exercise program that's not going to be too intense up front and again turn that person off from exercising regularly, because too vigorous exercise can trigger attacks in some individuals. Plus, if you go all out on your exercise regimen in the first few days, you're going to be very, very sore and you're not even going to be able to exercise for several days later. We're now going to continue on to some frequently asked questions about migraine, starting with, when is imaging warranted? The short answer is almost never. But there are guidelines to help guide your decision for imaging in headache disorders. And this slide shows you a snapshot of just 3 of them. You may be familiar with the Choosing Wisely campaign, which is applied to a number of different disease states to help clinicians make wise choices when deciding on diagnostic testing or other interventions for their patients. In short, somebody who has a stable pattern of headache that meets criteria for migraine should not be imaged. If you are going to institute imaging, CT is not preferred except in the setting of trauma. When MRI is available, you want to utilize it because it gives you much more information than a CT scan can. Now, our own American Headache Society has guidelines which indicate, again, it's not necessary to do imaging in somebody who's got a diagnosis consistent with migraine and the absence of red flags. If you really want to get into the nitty-gritty details for a broad spectrum of headache presentations, I would point you to the American College of Radiology's appropriateness criteria for headache. This is a terrific resource that gives you evidence-based guidelines on what types of imaging to consider. It's not like a yes-no, there's a gradation to it based on specific clinical scenarios. And so I often will refer to these appropriateness criteria for headache when considering what imaging studies I want to do, and also when teaching our trainees. The next frequently asked question is revolving around vascular health, particularly cardiovascular health and the triptans. I mentioned before that triptans have vasoconstrictive properties and would not be good for somebody who's at high risk for cardiovascular disease. But let's talk a little bit in detail about what we know about triptans and cardiovascular safety. Now, most of the triptan data that we have available to us from clinical trials excluded participants if they had significant cardiovascular or cerebrovascular disease. So it makes it a little bit challenging to ascertain the safety in the real world. In addition, as mentioned earlier, chest symptoms, this tightness, this tight feeling with jaw pain and nausea, that kind of sounds like it could be a heart attack, right? So somebody who's at risk for such probably shouldn't use a triptan because they may confuse triptan sensations for an impending myocardial infarction or vice versa. Now, we already touched on the fact that the incidence or the inclusion of participants with serious vascular disease does not happen in clinical trials, and therefore the incidence of serious vascular events is extremely low in clinical trials. But it also happens to be pretty low in clinical practice, even when unidentified vascular disease is exposed to a triptan. That being said, always we should exercise caution and take into account a risk-benefit analysis. Consider the profile of the person, the profile of the triptan, and you may be able to use a triptan if it's not an absolute contraindication. But absolute contraindications would include active coronary artery disease, a history of stroke, particularly recent stroke, the presence of peripheral vascular disease, and uncontrolled hypertension. Almost no one would prescribe a triptan in these situations unless it was a very, very dire situation, which again is why it's so comforting to have medications that may be safer in these circumstances. That being said, just like with the triptans, the gepants and the ditans have been studied in large part in the absence of any significant vascular disease. Some vascular disease was present in the clinical trials, or I should say some of the participants in clinical trials had vascular disease, but it was considered stable and without any acute events for at least 1 year. Our next question is still in the vascular realm. So what do we tell patients about stroke risk with migraine? It's a question I get a lot. So we know that the risk of ischemic stroke is more strongly associated with migraine with aura than without aura, but it's associated no matter what. And this risk seems to be most apparent in the population that we would otherwise not consider at very high risk for stroke. So young women, particularly using oral contraceptives and with smoking in the picture. Now we know those latter two are risk for vascular events and thrombotic events. So the situation you probably want to avoid is a young woman who is on oral contraceptives and who smokes. You want to counsel her that she would maybe otherwise not be considered at risk for stroke, but her risk is higher. That being said, the risk is still relatively low. A young woman has about a risk of 4 in 100,000 for having stroke if she is otherwise healthy. When you add these other risk factors of migraine with aura, stroking, and oral contraceptives, that risk increases by about 8 to 10-fold. When you do the math, you realize that that's still pretty low, about 40 max per 100,000. Still, it's best practice to make your patients aware that this could be a possibility. The other question that comes up is, what are these little stroke-like lesions that we often see on brain MRIs in people who have migraine? This is another reason not to just order MRIs willy-nilly, because you're probably going to see some of these white spots, and the radiologist might read it as silent infarctions, and now your patient is super worried. I'm 25 years old. Why do I have silent infarctions? Is it because of my migraine? Well, it may be because of your migraine that you have these lesions, but we don't think that they're silent infarctions. We don't have any evidence that these are actually strokes. They just look that way on the MRI. Moreover, they're not plaques from multiple sclerosis, another thing that they're often mistaken for. And we theorize, but we still don't have any direct evidence, and this is a research gap that may interest some of you, that you would think if you're doing everything you can to reduce the burden of migraine disease and instituting good preventive therapy to reduce the incidence of attacks, that we might reduce stroke risk. Well, we're not changing the biology of that individual, and the reasons that migraine is associated with stroke risk are still unclear. And so you can mask migraine all you want, but you might not take away that risk for stroke. I'm now going to turn it back over to Dr. Sprouse-Bloom for our favorite part of this presentation, the migraine mythbusters.
Number 1, migraine equals severe headache. So I alluded to this at the beginning, that most people think migraine equals severe headache, but all the symptoms of migraine are just as much migraine, and you can have migraine with no headache at all. Myth number 2, this is a very pervasive myth, that migraine is due to stretching of blood vessels. That's how I was trained. So it turns out that now that we have good imaging techniques, we can see that during a migraine attack, you can have changes in the caliber of visualized vessels, but you don't have to have them. So the take-home message is that there is a vascular component of migraine. It's considered a neurovascular condition, but at this point, we do not believe that migraine is purely due to a stretching of blood vessels. Myth number 3, migraine headache must always be throbbing. So very commonly, migraine is throbbing, but not all the time. And remember the International Classification of Headache Disorders, you can Google it. It's one of the criteria, but you don't have to have it to make a migraine diagnosis. It's similar with aura. Only about 1/3 of people with migraine have aura, whether it be a visual disturbance, a speech problem, a sensory disturbance. So you don't have to have migraine aura to diagnose someone with migraine. Myth number 5, this is a common one in the headache clinic. The myth is that sinusitis is a common cause of headache. We all hear about sinus headache. Turns out there has been good studies where there was CAT scans of the sinuses in people with proclaimed sinus headaches. It turns out that when the severity of sinus disease was graded, and there's 3 different scales that were used in the study to grade it, the severity of disease in the sinuses did not correlate with the severity of mid-face pain. Migraine often presents mid-face, and when it does, people think that they're having a sinus problem, when oftentimes it's migraine presenting mid-face. Myth number 6, neck pain is rarely a symptom of migraine. So Dr. Nahas alluded to earlier the connection between the upper 2 cervical nerves and the trigeminal. They come together. And that area in migraine where they come together can be hyperactive or sensitized. And what I tell patients is basically the brain can't tell where it's getting signals from. And they end up with pain at the base of the skull, upper neck, as a result. Myth number 7, triptan should be avoided in patients with aura. I've heard this occasionally, and it's just not true. I think the thinking has something to do with stroke risk and things like this, but this is not the case, and we don't avoid prescribing triptans for patients with aura. The 8th and final myth is never prescribe triptans when people are on serotonergic agents such as SSRIs or SNRIs. The concern there is worry of serotonin syndrome. In reality, this is exceedingly rare. These are as needed medications, the triptans with serotonergic activity. And I have never seen a case of serotonin syndrome triggered by a triptan. I'm not saying that case reports don't exist, but I don't hold back when I see a patient on even more than one serotonergic agent from prescribing them a triptan for PRN use. So in summary from our talk, make the diagnosis, give the patient with migraine something that they can hang their hat on. They might not embrace the fact that they have migraine, but at least they can rest, say, being able to call this weird constellation of symptoms that can last days and prevent them from working. At least they'll know what to call it. Now they can pursue treatment for it. Rule out secondary headaches. So remember the Snoop mnemonic? If a patient comes to you with symptoms or they have signs that suggest an alternate cause, then consider labs or imaging based on the etiology suggested by the symptoms or signs. And remember, the imaging is typically not needed in people with migraine. It's when they have secondary sort of Snoop things that you might consider it. Provide acute treatment. All patients with migraine should be equipped with acute treatment strategy. Remember, picking one from each of those three boxes and allowing the patient to choose what to do is often the most effective strategy. And lastly, when a patient has 4+ headaches, 6+ headaches, you have to weigh the number of headaches plus the severity of disease. Offer prevention. If they're overusing acute pain relievers, being on something for prevention can often be life-changing. So for more information, we have a full website of resources for you. Please visit the American Headache Society. We have the First Contact Primary Care whole website dedicated to you. It's growing. There's videos, there's podcasts, there's all kinds of resources, a flow chart. And so, when you need resources, we hope that you will rely on us for them.